Elizabeth Melado is a certified rehabilitation registered nurse with a master's in nursing and master's in business administration. She has worked for New England Rehabilitation Hospital for 10 years and has been a nurse for 11. She spent her first few years as a bedside nurse and cross-trained into different roles within the hospital. In 2022, she transitioned to the role of nurse manager at the neuro unit and has been growing in this role ever since. She's been an active member of the brain injury team for most of her time there and was recently promoted to co-leader of the team. Please join me in welcoming Elizabeth.
Okay, so I have never done this before. This is a new adventure for me. I apologize if my voice is shaky and if I talk too fast. This is all part of my growth journey. I just keep telling myself that. For those of you who don't know me, which is almost everybody in this room, Suzanne Morneau is my mom and Mindy is my sister. So now that you've put that together, when you look at me, you will see them and you'll be like, duh, you look exactly like you're a family. There's a bunch of us, we all look the same. So yeah, I have been at New England Rehab since 2015. I started here in Presque Isle at the nursing home that was also a rehab SNF facility. And I was there for a little over a year. I learned a lot in my first start of my nursing career and how to handle death and dying. It was just, it seemed to be the theme of the nursing home at the time. And it was good because it was something that I was extremely uncomfortable with. And then one day I got a call from Mindy, who was doing outpatient rehab services at New England Rehab, and she said, "Liz, you'll never guess what. I think I got you a job." Hold the phone. I'm comfortable in Presque Isle. It's cheap here, and I love my job. I don't want to learn new things. And she had run into the director of HR in the hallway while she was there, and she struck up a conversation because if there's one thing that we all know about my mom and my sister is they're extremely friendly. They like to talk to people, especially my mom, everywhere she goes. So I think the turnaround time was like a couple weeks later. I had an interview over the phone. I was talking with the HR director myself, and then shortly thereafter I went, we moved, my husband and I moved down, and it was the furthest away from home I'd ever been because I'm from Fort Kent. Fort Kent was comfortable. I've lived a very comfortable existence up until this point. So Portland was a big jump for us, and I really didn't expect to love it so much and to become so passionate about it, but I think being on the family side of experiencing life after a traumatic brain injury, I was there the day that Mindy got hurt. I finished the soccer game in the same position that she had just gotten taken out in and watched the helicopter fly over the field when she was taken by life flight to the hospital. So from the beginning of her journey, I was kind of there. And there were times that I went to Portland with her to go to some of her outpatient services, and I got to know the outpatient department pretty well. Outpatient rehab and inpatient rehab are very different, but I think oftentimes we get a little bit confused and there's this blurred line of what does a patient really need, where are they at in their recovery journey. So hopefully when we go through this, you'll get a better understanding of inpatient rehab. There's not a lot of services in the state of Maine for inpatient rehab. I was just talking with some new friends upstairs. They work over here in Presque Isle at the hospital, and they have a 5-bed inpatient unit. New England Rehab is a 90-bed facility. Our census is lying about 68 right now, which is the highest we've been since COVID. Prior to that, when I first started on the floor, we were hovering mid-70s. We have 2 nursing units. The way that they're split, the first floor is neuro and the second floor is ortho. So within those 2 units, we have 4 Joint Commission certified programs. Being the nurse manager of the neuro unit, I am blessed to be a part of 2 committees. One of them is the BI committee, which I am a co-leader of, and the other one is the stroke committee. I don't co-lead that one, but an avid team member nonetheless. So we'll get right into it. Feel free to raise your hand if you have a question in the middle of it. It's a lot of information on the slides. I'm not going to read verbatim every slide. I'm just going to give you the down and dirty, and then we'll go from there. I'm also probably not going to take an hour, sorry. I didn't want an hour, but they gave me an hour. So general overview, we'll talk about New England Rehab as a whole, patients before, during, and in preparation for discharge. What is it to be a part of a Joint Commission program? And then we'll talk briefly about brain injuries, stroke, and our committees, and then a smidge of community involvement. The most flattering picture of the hospital. This one, Kelly was almost a little bit embarrassed to give this to me, but this is what we have. So we are encompassed within a main med building. So the building itself is massive. We are 2 floors sectioned off from the rest of the building. So a lot of what you see is not actually what we have. These are our core values. I just think it's really important to know that we as a hospital, we strive for excellence just as every facility does, and we care a lot about setting the standard, leading with empathy, doing what's right, focusing on the positive, and being stronger together. We look to recognize staff that are really excelling in these areas. We've done a lot over time to just promote, it's not just we show up to work and care for the patients, but we want to provide quality care for those patients. We want to represent the company of Encompass Health well, and we want to strive for excellence. So those are our core values. And then we're gonna give it down and dirty from admission to discharge. So we have many different departments that are encased within the care of a patient at New England Rehab. It starts before they even come to us. We have a team of liaisons. We have an entire admitting department. They vet every patient that comes through our doors. Whether they see them in person or they vet them from a distance, they still go through. We are required to provide certain information about a patient prior to admission. All of that information is compiled into a document. That document is then sent to the providers, and our medical director is one of the primary providers who will go through and approve patients to come to us, but they have to meet certain criteria. They have to still be sick enough to be in the hospital, but they need to be well enough to participate in 3 hours of pretty intensive therapy a day. That therapy is broken up between PT, OT, and speech. Not every patient qualifies for speech, but every patient has to have 2 of the 3 services in order to come to New England Rehab. Speech therapy is our smaller department because that's really reserved for patients who are appropriate for their speech therapy services. Whether it's cognitive deficits that we expect to return or it's swallow impairment that we expect them to get some return of, that would qualify them for speech services. So the liaisons the admitting department receives a referral, and because we're a joint venture partner with Maine Medical, they're our primary patients. We get a lot of patients from them, but that doesn't exclude other hospitals. We get patients from all over the state of Maine, and we get patients from outside of the state of Maine. We'll have patients that come to Maine on vacation. They end up having, a massive stroke or a cardiac event or sepsis, like something brought them to the hospital. They're not safe enough to go home yet, but they really need a little bit extra care. So they'll come to us and then we'll discharge home. So we need to know before they come to us, what does that look like? What are we expecting from their prior level of care to what needs they have in the hospital to what we're expecting to send them home doing. So the liaison, if they do the pre-screening, gets submitted for approval from the provider. If we're heading in the direction of bringing the patient to us, they'll meet with the patient, again, if the patient is local. We have liaisons that go to Maine Medical Center, previously Southern Maine Healthcare, that's now within Maine Medical, and then we go to Mercy. We have sometimes liaisons that can go up into like the Augusta area, Central Maine Med, and different places like that. We don't typically have liaisons come into Presque Isle. That's not to say that we couldn't take a patient from Presque Isle. And in all fairness, there's more patients that want to come to New England Rehab than we're even able to admit on any given day. And then there's a lot of patients that want to come to us, but their insurances are like, they're not really appropriate for that level of care for a variety of reasons. So we're just picking the best we can and bringing in the most appropriate patients. So we like to set the scene. It's really important to prepare a patient and their family for what they're going to get at rehab because there's so much confusion surrounding it. But in all fairness, these patients have gone through something extremely traumatic and their families are going through something extremely traumatic. It's not cut and dry, it's not the same for every patient, they don't all retain the same information, but we do give them all the same spiel. This is kind of a general overview of what to expect, and then they come to the hospital, and then we reiterate that in every way, shape, and form that we can in their first few days at New England Rehab. And then the liaisons are really good about handing off appropriate information to the hospital, whether it's to the nursing department, to the therapy department, to the providers, whatever that looks like. They try to bring in even things, it seems so simple, but it's important to know what's going to make a patient stay more comfortable. Do they have a nickname that they go by? Do they have a pet that is the most important thing in their life? Do they have hobbies that they really want to get back to? What goals do we think we're really going to be setting with them that are appropriate for discharge? So we like to kind of get all that information, hand it off, and then ensure hopefully a smooth transition. But I think as any medical professional can tell you, transitions are not always smooth. And there's a lot of things that get lost in disconnect between facility to facility. And then sometimes we're just starting fresh. We're trying our best to learn about this patient in their first few days at New England Rehab. So that gets them to us. Admission starts. And the minute that a patient is admitted to New England Rehab, we start the assessment period. Day 1 is the day they're admitted. That could be at 9 o'clock in the morning, that can be at 9 o'clock at night, whatever that looks like. Again, it's different based off of when patients are transferred to us. But they come to us, we start assessing the patient. Nursing is primarily going to be seeing the patient on day 1. We do their full admission, their head-to-toe assessment, we get all of their background information, their adult history, and all of that jazz. And then we start looking at their mobility, and it's really, really important, and it's sometimes hard to capture the depth of this. It's really important that we're assessing their mobility on day 1. And the reason for that, we'll talk in future slides, is that assessment from the nurse to the therapist, it doesn't matter who is putting in the information, affects the patient's length of stay. The goal is to get patients as long as they need medically to be at New England Rehab. So we start assessing immediately. So like I said, every patient gets a PT and OT, and then some get speech when applicable, but every patient also gets a case manager. Every patient gets a provider. We have a very robust group of providers. We have rehab physicians, we have internal medicine providers, we have an osteopathic provider, we have a podiatrist. Another one of those things, if you're in the medical field, podiatry is hard to come by. So if we can get a patient seen before they leave, it's best case scenario. Some of them are not established with podiatry, and some of them will never be established. So we try really hard to do little things like that while they're with us. And then, of course, our pharmacy team, our dietitian is phenomenal. She works really closely with us. And then we have our nursing staff. So my knowledge and my depth of experience, although I understand what everybody does at New England Rehab, I might not be able to answer all of your questions that are specific to different disciplines. So like when we get to the end and people want to ask questions, if I don't know the answer to it, I will get you the answer. I just have to get the right person to answer it. And it comes from this team of caregivers. But within the nursing department, we have CRRNs, which is a certified rehabilitation registered nurse. We have RNs, we have LPNs, and we have CNAs. We call them RNTs, a rehab nursing tech, but they are essentially the role of a CNA. And then we get into that day 1 to 3 assessing current level of function. Day 1 is day of admission, and then for 2 days after, we are documenting ADLs, mobility, and all of those various tasks that a patient is doing, of how independent they are completing these tasks and how much intervention they need from staff in order to complete them. Our average length of stay, we call it about 10 days. Some patients stay a little bit more, some patients stay a little bit less. The reason we get that average is because our neuro unit can hold on to patients for a little bit longer. If we have a very impaired stroke that has come in, their insurances might give them 28 days, and that's amazing. And then upstairs in our ortho unit, those hip fractures that came in, depending on their pain and their mobility, they can recover pretty quickly, and they can be home within the week. So we get that average. During the 3 to 7, we'll call it interdisciplinary care. Every department is caring for this patient. They're monitoring how the patient's progressing. They're communicating with the other disciplines to see what interventions do we have in place. And then we are always thinking of what interventions do we have to have in place in order to get this patient home. The goal is always home. Discharge to community shows that the patients will have the best outcome, although I can sit here and tell you that the studies do show it. Patients transitioning home tend to continue to still progress. Not to say that we don't send patients to other levels of care. Skilled nursing, long-term care, memory care units, assisted living, all of these are options for the patient. They're just not necessarily the best option. In some cases they are though. And then we get into the days 8 to 10, we're evaluating the progress that we've made from day 1. We are gonna get into some like visual stuff a couple slides out that's gonna show what we're assessing and how we're assessing it and all that jazz. But basically we're looking at patient came in at this function. The goal was to get patient home. In order to get them home, these are the resources they have. This is the level of function they need to be. A patient might come in and they're dependent for transfers. It takes two people. They might be a Hoyer, they might be a slide board, they might be a sit to stand, whatever that looks like. But to get them home, they can't be using an assistive device to that extent. They might need to go home and be able to use a walker. Is that feasible? Probably, possibly, maybe not, but we're gonna assess it out. We're gonna assess how the patient's progressing, and then we're really going to have those harder conversations of, is home appropriate? Yeah.
One of the difficulties that I have on the social worker at Perry Medical Center is that we have individuals that come in walking,
Yeah.
but then all of a sudden, there's something neurological going on.
Mm-hmm.
We don't have access to neurology.
Yeah.
I see this a lot where a lot of people become letter of denials because we can't provide the service,
Mm-hmm.
and then we end up transferring them for the day for procedures,
Yep.
say in Bangor, Portland,
Mm-hmm.
and of course that's on the dime of the hospital.
Yeah.
My question is, have you ever seen individuals go to a setting such as yours
Mm-hmm.
to see a neurologist to get answers for what might be happening?
Not at our setting. So if a patient requires that level of intervention, we have to send them to a different level of care as well. So they come to us from main med, but their neurologist is at main med, or the neurosurgeon, whichever they need to see for whatever neurological deficit they're having. They come to us, they might be doing really well, and then there's a variety of things that can affect a stroke recovery, for example, right? You could have recrudescent in the setting of a UTI. And all of a sudden the patient is now a Hoyer assist for transfers. And then if you treat the UTI, it's great, but you still have the symptoms of the recrudescence. So you still have to get back to prior to all of that. We might send a patient over to main med for evaluation. They need to be cleared by a neurologist to return to us to show that what they're dealing with is treatable. And then we will treat it and we will work through the symptoms that they're experiencing because of it. But we aren't the diagnosing factor.
That's what I wondered.
Yep, in a perfect world, we'd have all the specialists and we'd be able to do every intervention for our patients, but the reality of acute rehab and the specialty that it is they come to us with intent of getting better, and if they get worse, and there's a reason why, we might not be able to completely diagnose and treat it. That's not to say though that we won't take the patient back. We do get a lot of return from, we'll call them an LOA, leave of absence. They go out to main med or to Mercy and then they come back to us when they're ready to go back into therapy and things like that. And then preparation for discharge preparation for discharge really starts before the patient comes to us, because the liaison is assessing what is discharge going to look like. And then they hand off to the case managers and they're like, hey, this patient came from home. These are the resources that they have. This is what home is set up like. This is where home is. And then we continue that and we work on getting them to that level if it is appropriate for that patient. So the case managers really bridge the gap between all of the disciplines. Nursing, therapy, providers, dietitian, all of them come together. The case manager pulls together all that information and then communicates directly with the patient and the family. We never take away the independence of a patient that's able to make decisions for themselves. We provide them with the tools that they need to make an appropriate decision. We provide the family and the friend, the caregiver, whomever is going to be helping support this patient with the tools they need to do that. But we don't take away from a patient's right to choose. But again, that's every setting that cares for a patient. If we really truly are concerned about a patient's capacity to make decisions, that's a different conversation though. We do have neuro services, a therapy service that we have, we used to have I always get them confused, a psychiatrist, now we have a psychologist. But he is telehealth services and he's very limited availability because we're just working on building that back. Our prior service, he retired. Dr. Cunin, who, the only person in this room who will know is Mindy, He was instrumental in her recovery, and he was huge in the recovery of all the patients he cared for during his time practicing. But he's now retired, God love him, it was well deserved. And we had to come back from that loss, so we're working on that because there are a lot of resources that our patients need even before discharge. So ideally, we want to send a patient to the community. 80 to 90% of our patients discharge home. Home looks different for everybody. Home could be the home that they were in before. Home could be to a different home with a family member. Home could be home with services in the house. Maybe they have 24/7 caregivers now. Maybe they have intermittent supervision because that's what they need. Maybe they have hands-on, whatever that looks like for the patient. We discharge home to homeless shelters. We discharge home to hotels. We discharge home to other states. That's always an interesting discharge because coordinating from state to state is quite complex. But we have successfully transitioned patients to the airport, to home. One case that comes to mind that I think was really interesting is we had a patient who came to Maine from somewhere down south, I can't remember the state. He had a massive cardiac event and required a left ventricular assistive device. And once the LVAD was placed, he had a massive stroke shortly thereafter. And now he's dealing with a stroke on top of a new cardiac device, which is, you live your life on a battery with an LVAD. So the recovery is very complex. And now he wants to go home, but he physically is not ready to transition home. He's not ready to travel safely. So he came to New England Rehab. He got sick. He went back over to MidMed. He came back to New England Rehab. We discharged him on his second admission to the airport to home. We transitioned all of his LVAD services to a different state. He coincidentally had a daughter-in-law who was a rehab nurse, so that kind of worked out really well. She came to me and helped transition him home. So home is different for everybody, and equipment is different for everybody, so we go through that in preparation for discharge. And then I just put here some of the additional resources that we do. Personal care agencies, we work with the Brain Injury Association's Neuro Resource Facilitator Program, Rehab Without Walls, traditional home health agencies, and DHHS main care services. Quality indicators are important. This is gonna get, sorry if this is boring stuff. This is like the meat of what we do in rehab though. Our quality indicators are required by the Centers of Medicare and Medicaid Services for all inpatient rehab facilities. So it's a list of it's a standardized assessment tool that allows the different disciplines to assess a patient's current functional status, monitor progress, and evaluate appropriateness for discharge. There are 12 different sections that include documentation from 9 different disciplines throughout a patient's stay at New England Rehab. The data is pulled from the patient's chart. Our PASS coordinator and that department, they take the information and they submit it to CMS from our admission and discharge assessment periods. So the 3-day admission assessment period starts on day of admission and it includes a lot of documentation from nursing, therapy, and case management. And then we have the 3-day discharge assessment period that ends on day of discharge. So that would be like day 3, 2, and 1. So 2 days before discharge. We're looking at all of that documentation. It's a 6-point scale that is used to describe the level of assistance required with each task for mobility and self-care. And if patients are unable to complete a required task, extra codes are used to describe why it wasn't completed. Why couldn't we do that assessment? Did the patient have medical needs? Were they in too much pain? Did they have severe fatigue? Did they completely refuse? Because they're allowed to do that. It's not what's best for them, but they are allowed to refuse to let us assess them. So we use different codes. TBE is to be evaluated. NA would be not applicable. If they didn't do this task before they were hospitalized, it's really not applicable to their recovery now. If they were wheelchair bound before, that's our goal. So mobility is going to be different for a wheelchair bound patient going home than it is for somebody who was independent before and needs to go home at a pretty high functioning level. And then for understanding and expressing tasks, we do use a score of 1 to 4, and it's based off of a patient's ability to understand but also communicate their needs. The goal is to see a patient at their highest level of function, even if it's day of admission. We want to see how much they can do for themselves without us assisting. And then obviously, if it's safe. If it's not safe for them, we're not gonna let them try to do things on their own. So we're gonna talk about some functional outcomes in these. I didn't get the most exciting graph, so I apologize in advance, but we'll talk about it. And then underneath the blue is where all the excitement happens. So self-care and mobility is broken up. We're going to look at 3 different patients. This is a patient who met all of their outcomes. That's why the whole graph is blue. So we were looking at eating, oral hygiene, toileting hygiene, shower, bathe, self, upper body and lower body dressing, putting on and taking off footwear. Tub shower transfer is not necessary for all patients to discharge because patients can discharge home at different levels. They might not need that in order to get home. You're gonna see the two different columns. If we took this graph when a patient was admitted, their scores here are lower. You're gonna see this total of 26 is different than 42. And then over here for mobility, rolling left to right, sitting to lying, lying to sit, sit to stand, chair, bed to chair transfer, toilet, car, walking at certain lengths, walking on even surfaces, curbs, 4 steps, 12 steps, wheeling 50 feet. This one's not necessary for every patient, and wheeling 150 feet, because again, if they're not going home at a wheelchair level, that's not applicable to them. So the way that it's grouped up is the things that are not necessary for discharge are not included in the total. Then you're gonna get 6 points for 7 things here to get to mental math, 6, 12, 4, 36, 42 for self-care. And mobility is 90, that one's easier. So in mobility, you see these scores on admission, 6, 5, 4, 3, manual. This patient, they came in, they were like a mod assist for some of these tasks, but they were not very low functioning. So 1 is dependent, 6 is independent. So that's how it's scored. So you're gonna see some setup cleanup, some min to mod, mod to max, dependent, and so on. So this patient was great. We got after discharge. He met all of his expected outcomes. This is a patient who had a traumatic brain injury. So this was midway through their stay. You're gonna see some different colored lines in the areas that are not yet touched upon. And the purple is the Encompass Health expected. The company nationwide would expect a patient with this diagnosis and this assessment to come here and get that. And then the red is the patient goal. The blue is where they're currently at. And then I really wish I didn't get a good one with a lot of open area for you to see even just the initial assessment. But you'll notice the numbers 6 and 4 and 5, like our patient came in at a 32. This is a traumatic brain injury patient. He came in very high functioning physically, but this doesn't always reflect just the physical. If he cognitively couldn't perform the task, it's not going to affect his physical ability to perform the task. So some of these numbers are affected by cognition. We call them walkie-talkies. They come in, they're pretty mobile, they might not stay for very long, like our patients who are coming in dependent. And then this was a non-traumatic brain injury patient. So they were a little bit earlier in their window. So we still had some room for improvement with self-care. Like patient came in, lower body dressing was completely dependent. Footwear was completely dependent. But then the patient was up to independent. So the numbers are kind of cool to see. Same thing here, like rolling left to right was a 1 and then became a 6. Toilet transfer was a 2 and then came to a 6. So patient made great progress. So we're just about ready for discharge. These graphs where they get pulled up into our patient's stay is for our caregivers to see during team conferences. So patients come in, they have an initial plan of care, and then they have to be assessed every 7 days. So we do team conferences once a week, and every patient is talked about. The disciplines all come together. In order to have a successful team conference, you have to have PT and OT, speech if applicable, nursing, provider, and case manager. And they all come together and discuss where a patient is at, and it's just the same conversations, where they're at, where they're going, and how we get them there. So this graph gets brought up, and you'll see differences throughout a patient's stay, and of course different diagnoses they're gonna have different information in them as far as how a patient is doing. So our hospital measures, the hospital as a whole is always looking at our discharges in total. We look at discharges to community, discharges to acute, length of stay, our CMI comparison, PEM trend, patient satisfaction, and employee engagement. The hospital cares not just about the patients. The hospital cares about the employees caring for the patient. We also care about how the patient's stay went, right? Patient day 1 might be a little bit upset with how the transition went. we attempt service recovery pretty quickly. And then throughout a patient's stay, we're always monitoring how they're doing. Is it going well? Are they getting the care that they deserve? How do they feel? Is this very subjective to the patient? How do they feel it's going? So we do care about whether or not they do their surveys and give us back that information. PEM trend is how the patient is doing with their, I did write it down and I didn't bring my notes in case you're wondering. The physical stuff, how they're improving on these. This is what we're trending for PEM. Our CMI comparison, we're looking at the patient's diagnosis, their medical complexities, their physical complexities and needs, and there's a number that gets generated based off of where they're at, and then that number is watched. It'll change when they discharge, right? We want that number to show improvement, so we're always looking at the CMI comparison. Length of stay is very important because length of stay is based off of a patient's needs, so we're trying really hard to capture what they need on day of admission, give them an appropriate length of stay. Sometimes we'll be able to challenge documentation, which is really great because everybody's always assessing. Even if they're not the one providing the patient care, they're assessing the documentation to say, does this all look accurate? Is there something that we didn't capture? Is there something that we captured that we need to really look at? Was it appropriate for the patient in that moment? And sometimes length of stay is impacted by that. And then of course, we don't love to send patients out acute, but it does happen. A patient might come to us and they have neurological changes. Maybe it's a new stroke, maybe it's not, maybe it's a new bleed, maybe they have sepsis, maybe their infection is just not controlled. Whatever that might be, maybe they fall and they hit their head and it's the middle of the night and we don't have radiology services. Maybe they're having new chest pain. We're really not sure if they're having a heart attack. We would then send patients out to be evaluated. Depending on that evaluation, they might come back to us same day, but they might not. They might need to stay out. So we're always looking at our discharge to acute, and the reason why that's important is because we want to know, did we do everything we could for this patient before we sent them out? Did we notice changes in their status quick enough to intervene before they became septic? Or did we notice neurological deficits immediately so that they could get the intervention they needed for that new stroke? And we meet regularly to talk about acute care transfers. And then obviously discharge to community because it has the best outcome for the patient. As far as nursing specific, we care a lot about falls. We care a lot about medication events, acquired wounds and acquired infections. Hand hygiene is just the bane of everybody's existence. The barcode scan rates is, are we scanning the patients and are we scanning the meds appropriately for administration to reduce error with medication administration? And then, it's not fall light response time, it's call light response time. Everybody approved that from the legal team, so we'll look at, I'll fix that later. They were just looking, I'll fix it. It's call light response time. We like to have an average response time of under 3 minutes. We kind of like to compete against ourselves between the units. Are we all responding to calls appropriately? One of the #1 complaints from patients is, nobody came to meet my needs when I needed them. And then the patient might have tried to get up by themselves and had a fall. Well, it's your fault, I fell because you didn't come. Well, it was maybe 30 seconds. You're gonna give us a minute. Sometimes that's the case, but sometimes it's not. Sometimes it's somebody came, shut the call bell off, forgot, didn't go back to do what the patient needed, and then it extended their needs. There's a variety of things that will come up. So we're always monitoring that to make sure that we are responding appropriately to meet a patient's needs. Therapy cares about patient intensity. Are they participating in therapy and getting everything out of it? Are they medically not appropriate for some of the therapeutic interventions? Or are they just refusing? Do they really want to come to us? Different things like that. They're looking at motor score, which is again that physical recovery, and then the quality indicators of self-care and mobility. It's the same thing as the motor score. It's all of that PEM information that we talked about. And then case management is looking at their own. They're looking at discharge. Did we give discharge instructions? Did we look at community resources for this patient? Did we provide everything in their preferred language? Portland, Maine is a little bit more diverse than Fort Kent, Maine, where I grew up. But that's not to say that Fort Kent's not really diversifying over time, but it's just a little bit different. We see different, we experience different, we have expanded who we care for, and sometimes preferred language is not English. So we just have to make sure that we're providing appropriate resources for those patients. And then they care a lot about discharge location, because again, goal is home, home's not always appropriate, and then they intervene to get a patient to the right level of care. And then advanced directives. We're always asking on admission if a patient has one, and if not, we're providing them with resources to attain it. It's really important for patients to have a say in their ongoing care, and it's best to do it in a document form so that people know what do you want when you need it and when you can't make that decision. So we are Joint Commission certified, like I said, in 4 programs. We have brain injury, traumatic brain injury and stroke, hip fracture, and amputees. Those are our 4 programs. We take patients from a variety of other diagnoses, but in order to say that we're Joint Commission certified, we have specialized in those 4 areas, and we get a little bit more attention from the Joint Commission in them. So the Joint Commission is an enterprise committed to advancing safety and quality, as well as transforming healthcare by encouraging, empowering, and supporting healthcare organizations to embrace quality improvement. They've been around for over 70 years. They are a driver of quality improvement and patient safety, and they offer expert resources and tools to enable those we serve. This is all information that you can get on the Joint Commission website if you're genuinely curious and you have a strong desire to nerd out about what the Joint Commission is and what they do. So this next slide is overwhelming with information. I will give you the abridged version. We want to be accredited. We have worked with the Joint Commission, as a lot of healthcare facilities have, to be accredited, but basically it's an objective evaluation of the care that we're providing. Are we improving our measures? Are we assessing and improving performance in order to provide safe, high quality care for our patients? It is awarded upon successful completion of an on-site survey, and the surveyors are selected at random. They come to your facility and they see where you're at and they let you know how to get better, basically. Surveyors will talk directly to staff and patients. It seems more intimidating when you look at it on paper than when they actually come into the facility, but that's a personal opinion of myself. Other people don't necessarily feel the same way. Surveyors come, they can be a little intimidating. But the survey experience, if you look at it from an outside view of you want to give the right care to your patients, you're going to see them as the resource that they are. They're going to come in and see the care that you're providing for your patient, the documentation to support that care, and really evaluate whether or not you can show room for improvement in a lot of these areas. So it's an extremely comprehensive review. Most have a positive outcome, some don't. And I can't say I've been a part of a survey that hasn't had a positive outcome, but I know there are hospitals that have. And then sometimes they come in between their cycle because things have arisen over time and maybe they need to immediately interject to see where you're at versus their regular schedule visits. And then they provide a lot of feedback. So the accreditation process is composed of different compliance structures. So the Centers for Medicare and Medicaid Services is a big part of it. They have 24 CMS co-ops that they're looking at. The Occupational Safety and Health Administration, OSHA, they have requirements protecting the safety of the employee versus the patient. And then the Joint Commission, they are patient-centric and focus on organizational systems and processes essential to the delivery of safe, high-quality care. And again, all of this is available online. So let's just go into, this slide also looks rough. We're just gonna talk through. When we're in a certification window, so this year is our brain injury certification window. They come every 3 years for all of our programs. Hip, amp, and stroke are all in the same cycle. Brain injury came at a different cycle because we had not certified at the same time as the others. So we're in our brain injury cycle window. So what that means for us is they're coming on site in the upcoming months. I think we submit all of our documentation this week, and then they can come whenever they want after that. The nice thing about a program-specific recertification is they give us a 7-day window of, hey, we're coming next week. And we get to prepare as much as you can prepare for outside visitors coming in and looking through all of your dirty laundry, because that's really what they do. But the most important thing is to be prepared. That preparedness is because you're taking care of your patients year-round. You're providing the highest quality care that you can provide. You're documenting to show that. You shouldn't have anything to worry about when the survey comes out, because you've been doing it the whole time. So with our programs, we'll get into stroke and BI and our program measures and what we do with our surveys, but we always know beforehand when they're coming. We meet and greet them. We have the whole thing planned out of where we're meeting, who's meeting. Everybody gets calendar invites for all the things. You look ready for the survey when they get there. And then they come in and they assess everything. They do closed chart audits, they do open patient chart audits, they go to the units, they assess the environment that the patients are in, as well as they'll talk directly to the patients. They go in, they close the door, they have a nice conversation, and the patients have the opportunity to be open and honest about the care that they're being provided. And then they'll pull different staff in. They can literally talk to anybody they want. They can ask whatever questions they have. So we just tell our staff, obviously, do the best you can. If you don't know the answer, there's always somebody who does. Don't try and make it up. That's where you could go wrong. Don't make up the answers. Find the person who has it and be confident in that. We start with an opening conference. We grab all of the key stakeholders. We do a little presentation of our program measures and what we expect and all of the data. And then they go into all of their tracers. And then quality improvement sessions happen. There's credentialing and privileging of providers. It's really important that the providers are up to date on their credentialing. Also that they do ongoing education to show that they are appropriate to be a lead of a program. Each one of our programs has a provider lead it. Alongside, obviously, the co-leaders of ours. We have me and a speech therapist that work together with the provider, and then our whole team is encompassed of PT, OT, speech, and nursing. We have one case manager, and it's pretty robust for the BI team. The stroke team is a little bit more robust. It's a bigger program for us, so they have more caregivers in each discipline, but every discipline should be represented. And then debriefing happens every day. They let us know how we're doing and they provide feedback. They pull all that information together in a really lengthy report, and then at the very end of the survey, they will report out on it. They will look at anything they caught that you were doing that maybe you shouldn't have, or where you said you were going to and then you missed something, or they'll say, hey, you did great. You're taking great care of your patients. Your measures are appropriate. Let's retire them. We do a lot of retiring of measures at the end of a survey because we've been doing them for 3 years. And then there's that nice little exit conference. So specific to our brain injury program, it's traumatic brain injuries. There are different ways that you can get a traumatic brain injury. You're going to see from concussions, contusions, intracerebral hematomas, epidural hematomas, subdural hematomas, and then diffuse axonal injury or shear injury. Earlier today, the gentleman who was up here to start was talking about anoxic brain injuries that happen after overdosing. We do get anoxic brain injuries as well, so we see a variety of these patients. They all come in with different clinical manifestations specific to them. Whatever part of the brain was affected is going to show different symptoms. But 2 patients can have the same injury and still recover differently and still have different deficits. This is just a lengthy list of all of the things that we've talked about in the other session, which is great.
Do you mind sharing that slide?
I can share whatever the people allow me to share here at the conference. I assume that they will share the slides, but that's just an assumption. I'll ask. So our program overview, community accessibility, sleep hygiene, the QO Libra overall scale, and then the TBI education. Each measure is specific to certain disciplines. So community accessibility, we want to get our brain injury patients into the community prior to discharge if it's appropriate. Community outings are a great way to see if a patient can navigate the grocery store, Dunkin' Donuts. How do they do with their finances? How is their motor planning? How is their processing in the grocery store? I think is one of the most exciting places to take somebody. How are they doing in the grocery store? It's important to know that a patient can transition back into the community. Sleep hygiene. In our last survey, the surveyor let us know the importance of sleep hygiene on recovery from a traumatic brain injury and how often sleep apnea is misdiagnosed. So we started the Stop Bang questionnaire, which nursing does with the patient to assess, are they at a high risk for sleep apnea? If they are at a high risk and they're not established already with a provider, we will give them a referral, leaving us to get assessed in more detail. The quality of life after brain injury, we do this scale on admission and on discharge to see how the patient has had the opportunity to identify areas that need to be addressed prior to discharge. So that puts a little bit of ownership on the patient. Mm-hmm.
What did you mean when you referenced a stop bang?
Yes,
What you said?
Stop Bang questionnaire.
What's
So the acronym stands for the different things you're assessing. I should have brought it. That would have been also helpful. Snoring is one, and that's where the S comes from. And then we're looking at blood pressure, neck size, which is surprisingly important. And then I don't actually remember all of it, but what I can do is I can get it for you.
And that
you can
helps
see it.
determine what?
Risk for sleep apnea.
Thank you.
Yep. And then TBI education, we have a cut sheet we provide to the patients that gives them hopefully a better understanding of their current injury and what we would expect as they're recovering. We also give it to families, and caregivers that are expecting to recover with the patient. Our stroke program, this just, again, all this stuff you can find very easily. Strokes, ischemic is 87% of strokes, hemorrhagic is 13. We see a variety of each. The clinical manifestations, we talk a lot about the FAST. BFAST, B-E-F-A-S-T is also an acronym that we use because in addition to the FAST acronym that everybody knows, balance and eyes are important. It's not just unilateral deficits, but are they all of a sudden unable to stand unassisted? Are they not able to see straight? Is their vision now blurry? Is it double? Is all of this new? That could be the tail sign of the person is having a stroke. And then in addition to the other things, headaches, numbness, weakness, loss of motor ability, dysphagia, visual deficits, self-care deficits, cognitive abilities. Stroke is the 4th leading cause of death in the United States, and it is the leading cause of long-term disability, which I just think is amazing to think about how many patients end up with strokes and the impact that it's having. Our program overview: nutrition education, diabetes, stroke risk factors, and then shoulder positioning. So our measures, we care a lot about the Mediterranean diet right now. That's the education that we're providing to our patients. A lot of risk for stroke is developed through lifestyle habits. So we have the dietitian who works very closely with our patients and documents in the nutrition section of the patient's chart the education provided. Does the patient understand it? Can they provide any teach back, and so on and so forth. Diabetes is also important. If it's a new diagnosis of diabetes, our interventions are going to be different than an established diagnosis, so we are looking at that. And then nursing is providing a lot of that education of how to manage their blood sugar checks and their insulin administration and different things like that. Stroke risk factor identification. We look at the patient's cognitive status, and then we want people who can to identify risk factors in their lives. It puts a little bit of that ownership back on the patient. And then shoulder positioning. Stroke patients who have a positive sulcus sign or pain to their shoulder palpation within the first 4 days of admission will receive education and demonstration regarding proper positioning and range of motion of the upper extremity. Because I'm not a therapist, all of that is usually, I take the direction really well from what the therapist tells me to do with the patient's shoulder, but I don't always understand the depth of the importance of it. But OT will document in their documentation, was it positive or negative? And then do they have deformity or subluxation in their joint? And then we do education and demonstration of the extremity positioning. And sometimes we'll go as far as we've taken pictures of patients in their slings or positioned in bed and put it up on the wall for families and nursing staff to ensure that we are providing appropriate positioning for this patient. And all of that is documented. And then our community involvement is ramping back up. We used to have a very robust set of volunteers that would come into our hospital, but because of COVID, we lost a lot of that, and we're getting back to it. We do have support groups that we offer prior to discharge to both the patients and their families. It's separate. It's important to give the patients their support group. It's also important to provide caregiver support. And it just looks different for both of them, so we want them to get the education specific to their needs. We do community education on stroke prevention and fall prevention. We go to assisted living facilities and provide fall education and stroke risk prevention. We do have a community stroke support group that comes on site once a month. Not that it's specific to this area, but if you guys know anybody who's local to the Portland area that would benefit from it, I have all that information upstairs at our table. And then we provide a space for other community resources. So Wings is an organization that comes to mind. They meet on site at the hospital. We allow people to utilize their space, reserve rooms for them, bring the community to a place where they can get together and really support each other through recovery. These are my wonderful resources. The Lippincott Manual of Nursing Practice is amazing, and then the Joint Commission website. And then everything else is specific to Encompass Health. Crushed it. 10 minutes for questions.
I have a few questions.
Yeah, hit me. I will do my absolute best.
What do you guys use for your liaisons that go to visit the patients in the hospital before they come? Like, is it like a nurse or a care manager?
They have to be licensed in therapy, nursing, something of the sort. So we have a lot of occupational therapists, some physical therapists, and then a couple of nurses that will go.
You have the neuro floor and the orthopedic floor, but you said you take other diagnoses.
Yeah.
So if somebody's like intubated and just chronic weakness and needs OTPT speech because of you know, prolonged hospitalization, do you take somebody like that?
We don't take intubated patients that
Well,
need to be
once
on a
they're
vent.
intubated, I mean.
Well, we will take trachs. Yeah, so they just need to not be on a vent to really be appropriate. But when we think recovery-wise, are they appropriate for those 3 hours of intensive therapy a day? Not every patient is. So they're always looking at, this is where they were before, this is where we need to get them back, and then assessing the intervention that we could
But they
provide.
don't need to be neuro, like they
No.
could be just a general weakness from,
Sepsis.
would they go to your neuro floor though?
Oh, they go where the bed is available.
Oh, okay.
However, if their needs are greater, we will do a room change to accommodate that, to get them on a unit.
Like if they need speech for like,
Speech can go to both units.
oh, they do?
Yep, absolutely.
So do your therapists float between units?
They try really hard to not. They have a team approach that they're working on right now where they care for a certain group of patients with a certain group of therapists, and they all have some continuity of care. But the therapist also could go to either unit if they were filling in or taking a
Right.
patient from somebody
So
else's.
some
place.
might be more like stroke
Yes.
preferred and.
Yep. Neuro is not for everybody, but also neither is ortho. I have learned that.
What about your outings? Do you guys have like a bus that takes patients places, or does the family member have to bring them to like
We
the,
have this delightful car.
like who drives, like is it,
Our therapist will take them.
they can take the,
Yep, and again, we look at are they medically appropriate to go into the community before we send them out, and then the therapist goes with them. Yeah, it's a very well planned event because it usually takes a little bit longer than the average, 1 hour session. Sometimes we might have to send them out for an hour and a half. What does that look like? We also do some home visits. If we need to get a patient home and home is local, but we don't know if they're really safe to be there. Will their wheelchair fit in the home because they're wheelchair level now, and different things like that. We might go into the home. Sometimes pictures suffice and sometimes they don't.
yeah. We do home evals, but usually like the family member takes them in their car and we take our car and meet them there. So like
Oh,
when
yeah.
we like the grocery store, I was just curious how.
Yeah.
You
The
take them in
grocery
your own
Yeah,
rehab car, or whatever you have, they don't take their personal car.
No, it's a hospital vehicle. Yeah.
So you can use that for practicing car transfers.
Yeah, we also have a really fancy, I should have taken a picture and put it in the slide. We have a fancy indoor car thing that goes up and down to meet the patient's needs for whatever their car might be for height. And we use that. I mean, Maine weather is unpredictable at best. So we do a lot of indoor car transfers. I think maybe only a therapist can truly appreciate the importance of having that equipment in
Then
a
you have to
hospital.
go up to the real car, rain or shine.
Anybody else? Awesome. Anybody else?
Best time to send the referrals to you guys? Do you want us to wait until they're discharge ready, a week before they're discharge ready? What's the best time frame?
I am not an expert. But I will tell you that we start the conversation pretty early in a patient's stay at their prior facility. I don't think there's anything wrong with sending a referral a week before. The problem is our pre-screens have to be within 48 hours of admission, so patients really can change a lot in 2 or 3 days. So we need the most up-to-date information of are they still appropriate to come to us, but get the referral in. The worst we do is have to wait a couple of days before we see how a patient's doing.
Well, a lot of times too, patients require prior authorization, so if you're waiting till day of discharge, you're already 2 days past.
Yep. Those prior auths are really the bane of our existence.
Very much so.
Will your referral team, not take in a patient because they'll hurt the starving?
Our referral team is not the deciding factor, right? They are just pulling together the information for the provider. And then the provider is looking at the patient's medical needs and saying, is this patient appropriate for inpatient rehab? We're not taking admissions to boost the numbers of admissions and discharges, although we're always looking at those. We have to look at, is this patient really appropriate to come to us? And a lot of patients think they are and they're not. Some patients will win an appeal to come to us. We do have patients who will fight tooth and nail to come. And then we have some patients who will be told, hey, you're really not appropriate to come, but they're willing to pay out of pocket. And we will take those admissions as well. But the referral source, our liaisons are not an end-all be-all. They are taking the information that's being provided and then asking the provider to say, this is everything you need. Can you make an appropriate decision for this patient? Anybody else?
Do you require,
How would you guys describe the difference between a family person, a family member, between skilled and acute rehab?
So, I think when we are looking at interventions, right? Acute rehab provides 3 hours of therapy a day. You're getting an hour from each discipline if they have all three, or an hour and a half from two. Skilled nursing facilities offer less, I think it's 30-minute intervals of therapy. And we're providing the 3 hours of therapy 5 days a week consistently. If they miss it on a weekday, we get it on the weekend. We are providing it. But patients still need to be medically appropriate to be in the hospital. So therapy aside, you know, we get patients with trachs, wound vacs, LVADs. We get patients with PICC lines that are requiring IV antibiotics, and the variety of medical needs. Not every skilled facility is appropriate for that discharge from a medical standpoint of nursing intervention. And then once we assess a patient's medical needs, then it's appropriate to say, okay, skilled rehab is more appropriate than inpatient rehab. But again, that comes down to the medical provider's assessment of the patient and do they really need our services.
Do you require family members to stay down there to participate in the therapy process?
No, we take patients again from a variety of locations, and not every family can. So we get sometimes creative in how we provide teaching and education to family. We love to have family present just before discharge if family training is needed, if we know a patient is not going to be independent in tasks. And some patients' families have to stay local because it's too far to travel back and forth and they want to be a part of that care. Our goal is to get patients, families, friends, caregivers involved as soon as we can, but that doesn't require them to be there 24/7. They might pop in one day here, one day there, but a lot of our families are very involved. That's how we're successfully sending patients home, is they have good support to go there. It's not the case for everybody though.
I just want a quick clarification on the team that you like co-lead for like the.
Oh, yeah.
I was just a little confused, like, is that just specific for like Joint Commission accreditation, or is that something
Yes.
that you guys do separate of that, as far as like just keeping everybody up to date on education, things like that, or is it like?
It's specific to the Joint Commission program, but it works to keep the hospital up to date in the care that it's providing the patient. So it's kind of multifaceted. The team members themselves have a higher level of responsibility than the rest of the hospital. But the co-lead that works with me, she's a speech therapist. Her name is Haley, and last week she went to huddles in every department to provide sleep hygiene education, because it's important for us to show that we're educating the whole hospital on sleep hygiene, and it's not just the stop pain questionnaire to see if the patient is a high risk for sleep apnea. But we would expect that she would do ongoing education that's appropriate to the team that she's on. I do have a table up in the whatever room we're in for that. So if you guys have further questions, I'm there. I have a few business cards. I was ill prepared. This is what happens when I travel with my 2 children that are the youngest in my family. I left most of my business cards in my office and rushed to leave. But I can provide my email address. If you have questions that are specific to other disciplines, I would be more than happy to put you in contact with somebody who can answer them if they're specific to a patient's needs while they're in the hospital. After 10 years, I consider myself a content expert, but I also know that there's always room to grow in my knowledge and expertise. Thank you.
Thank you, Elizabeth. Here's a little gift for speaking.
Thank you.
Thank you. Okay, so lunch upstairs.